Hi, good evening, everybody. The topic which I'll be presenting is vascular ring and sling. I find this topic particularly interesting, and we'll start with an equally interesting case, which is that of a 6-month-old girl who presented to the OPD with history of noisy and rapid breathing. She had feeding difficulties since birth and a few interspersed self-resolving episodes of cyanosis and apnea following bouts of crying. Now, during the OPD visit itself, the patient developed an episode of sudden onset cyanosis, apnea, and bradycardia, and actually became unresponsive. Following CPR, the child underwent intubation, etc., and was referred for a CT angiography as a vascular ring was suspected. Now, CT angiography was done, and it actually was a vascular ring, and that to a particularly interesting ring where we had a circumflex left arch where the left-sided arch crossed the midline to go on to the right side, and the descending thoracic aorta was right-sided. Here, it gave off the aberrant right subclavian artery. There was a ductus which connected to the right pulmonary artery, which can be seen in this second image. And all these components combined together to form a complete vascular ring, which was seen encircling the trachea and the esophagus and resulted in the dramatic presentation of this particular child. Now, the presentation will not always be so dramatic. This was a relatively simpler case, 7-year-old boy. He had history of dysphagia for solid foods and also history of recurrent pulmonary infections in the past. CT was done. We can see that there was presence of a double aortic arch. The arch is present on either side of the trachea, and the characteristic 4-vessel sign, which we are taught to look for in a axial CT angiography. So in this case, we saw that both the arches were of a similar size. They were seen giving rise to the respective carotids, common carotid and subclavian arteries. And this ring was causing mild indentation on the trachea. And obviously, we did not see any respiratory symptoms as the compression was really mild. And the symptoms were mainly related to the esophageal compression. Now, the arches are not always codominant. Sometimes one of the arch is more dominant, as we can see in this third case, that the right arch is thicker, wider in caliber, and the left arch is non-dominant. The 4-vessel sign is seen as in a codominant double aortic arch. On the volume rendered image, we can appreciate the non-dominant left arch. But even though one of the arches is non-dominant, we can actually see that the compression is comparatively more significant in this case. Now, in cases of double aortic arch, it is not always that both the arches will be complete. We do have cases where one of the arches has partial atresia. In this case, we can see that the left arch has distal partial atresia, and better appreciated on this volume rendered image, where posteriorly we can see that there is sort of a luminal discontinuity between this diverticulum, which is arising from the descending thoracic aorta, and the rest of the left arch. Again, we can see here that it's causing significant indentation on the trachea. Now, this is one field where MR angiography actually scores over CT angiography, because CT angiography will not be able to show this atretic segment. However, you can see a fibrous structure as a hypointense band on MR angiography, which was also done in this case. Now, if we are faced with a double aortic arch or one of its variants, it's very easy to make a diagnosis. If not, we will be faced with one of these two scenarios. It can either be a left-sided aortic arch, it can either be a right-sided aortic arch. Now, when you see this, if you're suspecting a vascular ring, in all cases, half of the ring is already in place. You will have this arch and sort of, part of the right pulmonary artery. You will always have half of this ring present, irrespective of whether it's a left arch, right arch. Now, what we are looking for is the posterior wall. Now, what can form the posterior wall of a vascular ring? It can either be an aberrant subclavian artery, it can be a Commerell's diverticulum, or it can also be a circumflex arch, where the arch itself will extend behind the trachea and form the posterior wall. Now, the remaining lateral wall, which is contralateral to the aortic arch, it will always be formed by either a patent ductus arteriosus or a ligamentum arteriosum. Now, you can make different permutations and combinations with these three structures and find the various possible rings which can cause or form this complete vascular ring. We'll see a few in the coming examples. Now, in this case, we see that this child, 2-year-old boy, presented with dysphagia for solid foods and occasional dyspnea. Here we see that the arch is left-sided, but a comeral's diverticulum giving rise to an aberrant right subclavian artery seen extending posterior to the trachea and esophagus. And this structure is forming the posterior wall. And then a ductus, which is arising from this structure and joining the RPA, is forming the lateral wall. So this thus completes the vascular ring in this case, better appreciated again on these volume rendered images. This is another example where actually the aberrant retroesophageal subclavian artery was forming the posterior wall. And again, we see that there is a patent ductus arteriosus arising from it, which will form the contralateral wall. And again, the vascular ring will be completed. This is the first case where actually the circumflex arch was forming the posterior wall. And again, a ductus on the contralateral side completed the ring. And thus we see various examples of complete vascular rings. Now the question is, can only complete vascular rings cause obstructive symptoms? The answer is a resounding no, because we have various examples where a single vessel can itself cause respiratory or esophageal symptoms because of compression. Now this one child, she was a 1-year-old girl. Now she presented with a single episode of apnea after crying, and she actually lost consciousness during that episode. Now here we saw that the innominate artery was arising more medial than expected, and during its course towards the right side, it was actually causing marked compression of the trachea, which is seen on this axial as well as the corneal images. And if you see the volume rendered image, you will actually see that this is the most severe compression which we saw, in all the cases which we have seen till now. So this is known as the innominate artery compression syndrome, and a single vessel is actually causing these dramatic symptoms. This is a very interesting sling which we learn about. This patient, we actually found this sling during a routine preoperative evaluation. This patient was actually being evaluated for atrial septal defect, and we found that the left pulmonary artery was arising more rightwards than normal and then forming a sling around the trachea before supplying the left lung. So this pulmonary artery sling can also be a cause of respiratory symptoms. Here we can see the sort of sling from where it derives its name. This LPA is forming a sling around where the trachea would be. This is another rare entity where actually the LPA is normal, but there is an anomalous branch which is arising from the RPA and going and supplying the left lower lobe. Now this is what we call as a pseudopulmonary sling. In this particular case, it was not causing any significant compression of the bronchus, but if it would have been more medial, it could have caused tracheal or bronchial compression. So this is what is called a pseudopulmonary sling. Now, other vascular structures like a dilated comeral's diverticulum, it can also compress the trachea from behind and result in symptoms. Sometimes what we learn about what is called as dysphagia lusoria, just a retroesophageal aberrant subclavian artery can cause compression of the esophagus from behind and result in dysphagia. And even, there is no ductus to complete the ring, still this vessel on its own can cause symptoms. Respiratory, rarely, but esophageal, definitely. So what I feel is imaging of vascular rings and slings is not very challenging because there are a limited number of conditions which can result in these symptoms. And once you follow that algorithmic approach where you first rule out a double aortic arch, then on the basis of the sidedness of the aortic arch, you just look for the posterior wall or a lateral wall, and then just look where your ring is being completed or not. Or you can look for these entities which are incomplete rings or slings as we call it, and whether they are present or not. What I feel the most important thing is for the physician to have a high index of suspicion when the patient actually presents to them, because the clinical features will vary according to the age of the patient, the degree of tracheal compression. Now in infants, if we are faced with tight vascular rings, the patient may present with respiratory symptoms, labored breathing, stridor. In toddlers, usually we have loose vascular rings. The first symptoms are dysphagia due to transitioning from liquid to solid foods. Now, whenever we are faced with these respiratory symptoms, the clinical presentation may be misdiagnosed as a common respiratory condition like asthma or bronchiolitis. And hence, I feel a high index of suspicion is of utmost importance for early detection and management of these rings. And asymptomatic cases may also be diagnosed if the evaluation is going on for some other case. They may be left alone, or they may be treated if the patient is being operated for something else, because they may cause tracheomalacia at a later date. That's it. Thank you. I think that was my time.
Thank you, Dr. Neeraj, for showing such an